Can we talk about your secondary care colleagues for a bit? Because there are a lot of them who are concerned that they're being left out of the loop. Reginald Edwards asks, what are your views on certain clinical directors at trusts actively discouraging consultants from getting involved in the commissioning process with primary care or PCTs? How can consultants overcome these challenges? And I'll put another one with that. Harry Keane, again actually, who's a diabetes and endocrine specialist at Guy's, asks, do the GP members of the BMA consider that their consultant colleagues are adequately represented in the proposed consortium clinical policy making process? Are they out of the loop, the consultants?
Well, I can't immediately answer Harry's question because we don't know what sort of strictures are going to be placed on the make-up of consortia, but I have said right from the beginning that I was alarmed in the white paper that at the lack of mention of secondary care, because that's where most of the spending goes on, that's where a lot of the decisions go on, and that's where, certainly in the past, there used to be a huge amount of dialogue. And the problem is we've suffered too long in the NHS from this sort of rather artificial division between primary and secondary care. And unless we break down these barriers, then this isn't going to work. In terms of foundation trusts particularly, it's almost sort of preventing their consultants going and talking to GPs. That is an absolute nonsense that has to be stopped. And it's
Why do you think they're doing that?
Well, it's partly because of the market-based system, and they basically say, we're not going to have you go talking to these GPs if all you're going to do is flog off our business by shifting services out of hospital into the community. I think that's the way they do it, and that's one of the perverse nonsenses of some of the aspects of payment by results on the market.
There is this kind of unspoken law in a lot of organisations within the NHS that purchaser must not speak to provider because it's somehow going to help not help the business.
Well, it's not true even in normal markets out there. I don't know of any purchaser who's not in pretty constant dialogue with their suppliers. Now, the NHS is a completely different market. It's about trying to do your best for patients. And if you don't have all the people who are involved in designing and delivering the care of patients talking to each other on a very regular basis, then the whole thing will fail. And if anybody who thinks that because of this nonsense of the purchase-provider split, it means we can't even talk to each other, then they need to be drummed out of the health service because they're not people I want to work with.
So here we are, an anonymous email. How can secondary care be part of commissioning process? What role do you think they should play?
Well, I think there are roles at several levels. We still haven't decided on the makeup of consortia boards and who will be beyond that. But certainly there will have to be discussions about how service delivery is designed. And it's absolutely imperative that secondary care is involved there. But if there are going to be fairly major decisions about reconfiguration, of course they have to be involved. The other area we haven't mentioned too is public health, which again is vital in terms of the design of services, what responsibility local authorities are going to take, what responsibility GPs are going to take for preventative work. And again, we have been concerned about the lack of mention of public health. I know there's another white paper coming out on public health shortly, and we've tried to make sure that the government has taken note of our concerns in these areas.
We should move into just a couple of the other areas really, because it's not all about commissioning. I know that is what is taking up a lot of your time, but Colin Hawkmore, who's a student, asked a question on targets and outcomes. In a statement, the Health Secretary Andrew Lansley claimed that unjustified targets and bureaucracy could be simplified by outcomes frameworks, which could be developed by professionals. How will the outcomes frameworks, for instance, increase the proportion of stroke victims who are able to go home and live independently, where other frameworks have failed? I think that's a quote actually from Andrew Lansley's presentation.
Well, I think the best competition in the NHS is competition between clinicians, and for that they need to know how well they're doing compared to their colleagues. Most doctors get up in the morning wanting to do the best job they can, and they want a fair and accurate assessment of how well they're doing that job and how well they're doing it compared with others. So I don't think doctors should be afraid of accurate data that helps them decide how well they're doing, and of also sharing good practice. But that's quite different to the sort of competition that this government and even the previous government talked about. Developing good quality outcomes data is quite difficult. I mean, I was quite involved in trying to develop the quality and outcomes framework for general practice. And there were areas we had to leave out because just, quite frankly, there wasn't sufficient accurate, reproducible data. And in many areas, that is still the case. So there's a huge amount of work to do on that. But I think we've got to try to do it, because that's the way you improve, that's the way you judge how you're performing compared to others.
Jon, is there a worry that many of the lessons that have already been learned and the work that has already been done is going to be lost now with reorganisation and adopting of new systems?
No, I don't think so. I think the NHS has got a good way of dealing with its legacy. I mean, the information systems are going to be built on. General practitioners will be more involved in providing data to commissioners and enabling them to do innovative things. No, I think that the danger, as we've said right from the outset, is all about the split, the purchase provider split, and the potentially damaging market. Not none of, but quite a lot of the rest of the white paper, it makes some sense. The targets and outcomes make sense. You know, we have a lot of process measures at present, and in many cases, process measures are not a bad proxy for outcomes, but they're not about outcomes, essentially. If you can measure them, as Hamish says, if you can make the health service more responsive, then you have a better health service, and it's got a long history, 60-odd years of improvement. Who would have thought about that waiting times would have come down to the extent they have now, even as little as 10 years ago? Probably nobody.
That's a hurrah for targets, isn't it?
No, it's a hurrah for clinicians working towards sensible targets. There are certain targets which have had perverse incentives. We can all speak of stories about some of the 4-hour waiting targets in A&E departments which have been gamed out of existence almost. But it's a sensible. That target has made a lot of sense. It was worked very hard on by clinicians who had a lot of resources thrown at it, don't forget, a lot of financial resources thrown at it. And we're not in that position going forward. You can't throw financial resource at it. All you can throw at the health service is clinician time and effort now.